Exam Board Prep course for OB-GYN Board Prep. I'm Dr. Tessler, and I'm your faculty today that will be taking you through this examination. So let's go ahead and get started. Number one, a 56-year-old woman was exposed to diethylstilbestrol in utero. Her recent colposcopy showed signs of punctuation and mosaicism of the anterovaginal fornix. The most likely diagnosis is, this is answer B, clear cell adenocarcinoma. Knowing the relationship of diethylstilbestrol and vaginal clear cell adenocarcinoma is important. There are still women that have been exposed to this in utero that are seeing us in practices, and it should be recognized. Remember that there are other clear cell forms of cancer, but they are not related to diethylstilbestrol. This is unique to the vaginal form of clear cell adenocarcinoma. Number two, a 25-year-old G0 presents for contraception counseling. She describes taking OCP before for dysmenorrhea and abnormal bleeding, however missed pills multiple times. She wants a long-term solution. Which treatment is the best choice? This is going to be answer C, levonorgestrel intrauterine device. Remember, ACOG Practice Bulletin 135 makes it very clear, along with other ACOG literature, that offering long-acting reversible contraception is the best choice to talk about with patients, especially if they're not contraindicated for a specific choice. Number three, a 65-year-old has distal interphalangeal joint pain and swelling. Which of the following is the recommended first-line therapy? This is going to be answer B, acetaminophen. General measures for patients with what we are seeing here, osteoarthritis, are going to be treating the patient's symptoms with either splinting or immobilizing for discomfort, and using things such as acetaminophen. Remember that rheumatoid arthritis would actually involve the proximal interphalangeal joints. This would be treated with DMARDs, or disease-modifying anti-rheumatic drugs, such as things like Xeljanz. Now, the distal interphalangeal joint, as referred to in this question, is referring to osteoarthritis. Number four, which portion of an immature teratoma is most important to evaluate the grade of the tumor? The answer here is C, neuroepithelium. So just as many teenagers are immature because their brain is not completely matured yet, we remember immature is neuroepithelium. So just like immature teenagers need to grow their brain tissue a little bit more to be mature, immature teratomas are graded by their neuroepithelium. Number five, a patient presents for prenatal care at 36 weeks and complains of vaginal pain. There is a small 0.25 centimeter lesion on the vaginal wall. You swab the lesion and send for cell culture. Culture is negative for HSV. What is the next best step? The answer here is B, send type-specific HSV serologic assays. Now, another possible would be to complete a PCR. However, that's not listed here. Many of our institutions will use PCR as the first step to identifying HSV lesions and HSV types. However, that's not available for everyone, and this exam is for the generalist everywhere. So the CDC and ACOG agreed that it's important to know that if a cell culture is negative for HSV, then you do need to complete a type-specific HSV serologic assay, or if available or in line of usage, complete a PCR testing. 6. When is delivery indicated for controlled, without medication, chronic hypertension? This is answer C, 38 weeks. When it comes to knowing your preterm or early term or term deliveries, it's really important to understand a couple of disease processes. I would make sure that I know anything to do with diabetes mellitus or gestational diabetes mellitus. I would also know anything to do with hypertension, preeclampsia, which I'm going to put as pre-E, or things to do with multiples. These are common things asked about when people write examinations when it comes to delivery days. 7. A 32-year-old at 38 weeks presents in active labor with a known history of asymptomatic aortic stenosis. Which of the following is the first step in her management? The answer here is actually B, close observation. All we've told you is that the patient has a known history of completely asymptomatic aortic stenosis. So there's really nothing that really has to be done here. This patient can be watched and observed to make sure that they're not developing any signs or symptoms or problems of aortic stenosis. Now, the key to management overall is going to be the avoidance of decreased ventricular preload and the maintenance of cardiac output. So if this patient does require intervention, it's going to be to give them fluids and make sure there's enough fluid available to keep that backload there. Now, that means that we're going to be managing this patient on the wet side of things. So we want to make sure that we have that just in case if the patient has a hemorrhage, loses a lot of blood, and therefore loses that preload, we've got it backed up already. But again, for the woman with asymptomatic aortic stenosis, no treatment except close observation is required. Let's take a look at managing aortic stenosis and mitral stenosis. Aortic stenosis is managed in a wet fashion, as we just talked about, because we're trying to make sure preload is there. Now, mitral stenosis, we want to make sure we're managing that in a dry state. The reason for that is if the building up of fluids occurs, that patient will end up in a pulmonary edema. So if you don't keep them dry, you're going to end up in pulmonary edema. Now, a good way to remember this that's easy is if you take the letters aortic stenosis and mitral stenosis and put their letters below, if you put W or D in front of them, only one of them is going to make a word that makes sense, and that's was, W-A-S. So wet management of aortic stenosis is the only thing that makes sense. Dry management of mitral stenosis needs to be taken care of. Otherwise, you'll have pulmonary edema. Number 8, the obturator artery originates from which of the following vessels? This is going to be answer A, internal iliac artery. Now, we do have a saying that will help you with remembering the vessels of the anterior branch of the internal iliac, because that's where this vessel is going to be found. Now, that little saying is going to be O, U, U, M, I, and I. So if we're to fill those in, that's going to be our obturator. U is going to be our uterine. Don't forget that obliterated umbilical. The M there is going to be your middle rectal. The first I, we'll go ahead and put our inferior gluteal. And the second I will be our internal pudendal. So again, OUUMII might get you out of a pinch on an examination if you forgot what comes from the anterior branch of the internal iliac. Now, the posterior branch really is a lot easier. It's just an ILS. That's going to be your iliolumbar, your lateral sacral, and your superior gluteal. So again, ILS, which some people say I love skiing or I love surgery, as a mnemonic is iliolumbar, lateral sacral, and superior gluteal. Number 9, which of the following is not a finding associated with neonatal abstinence syndrome? This is going to be answer B, seizures. Be careful with the word using seizures with these neonates. Unfortunately, we see it used a lot with the patient, and they're just having shaking or withdrawal signs, but they're not seizing. So it's a careful thing to distinguish for the patient and for the caregivers around them. Seizures is not a typical finding associated with neonatal abstinence syndrome and may mean something much worse is going on. Now, neonatal abstinence syndrome is a high-yield topic to know. If you're not familiar with medications, we'll go over a little bit of the basics there for you next. However, you should know a little bit about them. Characteristics of neonatal abstinence syndrome are things such as hyperactivity of the central and autonomic nervous systems, which can cause things like shaking or things that may look like seizures to others, but are not seizures. They also may have uncoordinated sucking reflexes, which can lead to poor feeding and has to be monitored carefully. They can become very irritable and unconsolable in some situations, and they can produce a high-pitched cry. So I would make sure that I know those things that are part of neonatal abstinence syndrome so I don't confuse them with those things that are not. Let's take a look at some of the medications that are out there. Methadone is a commonly used and highly recommended medication for pregnancy for patients with opioid use syndromes. It's a potent opioid with a half-time of 22 hours. We do know that there are increased birth weights compared to patients who are using heroin. And also NAS is about 60 to 100% when using methadone. Longer neonatal abstinence syndrome than buprenorphine and heroin are noted with methadone. However, the NAS does show up earlier, usually in the first 24 hours. So again, I would know that methadone, NAS is more likely to be longer, and it's also to show up earlier. NAS symptoms are dose dependent, so depending on what our maternal level is or our patient's level is before the birth may determine what some of the NAS symptoms that are going to be seen in that neonate. Unfortunately, some patients know that the increased dosing can increase the risk of neonatal abstinence syndrome. Some patients are now refusing to increase their doses, but we know that withdrawal of medications or withdrawal of opioid use and substance use are much worse and will cause much worse outcomes in the pregnancy and possibly thereafter than the patient taking a higher dose and having some more risks applied for neonatal abstinence syndrome. Buprenorphine is an opioid partial agonist. Once taken, it prevents opioids such as heroin and other painkillers that work with opioid receptors from taking effect. It has a ceiling effect, little to no effect increase with dosage increase overall. Neonatal abstinence syndrome is known to have shorter hospital stays, shorter need for treatment, lower morphine doses, and up to 50% severe withdrawal. Suboxone contains buprenorphine, which we just talked about, and naloxone. So naloxone deters abuse, blocks the effects of opioids if they're taken along with the medication being taken, and high doses can trigger withdrawal. So it is risky for that reason. NAS onset, duration, and frequency. So taking a look at this here, you can see the onset of the different medications and substances that are listed, the duration of that neonatal abstinence syndrome, and the frequency that occurs with the usage or the exposure of these different medications and substances. Don't forget that SSRI medications are known for some neonatal abstinence syndrome. I would make sure that I pay attention to that. And I also would make sure that I know prescription opioids, as patients may be taking those in their pregnancy, not realize that it's a problem or complication, but then there's a neonatal abstinence syndrome that goes along with them. Number 10. What is the lowest cutoff for umbilical artery pH that confers neonatal encephalopathy was not related to intrapartum hypoxia? This is answer C, 7.2. If the chord arterial umbilical gases are at least 7.2, this confers the neonatal encephalopathy was not likely due to intrapartum hypoxia. Now remember, we're referring to these as things such as neonatal encephalopathy. We're not calling these birth injuries, and we're not calling these hypoxic events. So therefore, remember, refer to neonatal encephalopathy and 7.2 as a minimum of your umbilical cord gases on your arterial side can confirm that that's not related to intrapartum hypoxia. However, let's remember that fetal umbilical artery pH of less than 7 or a base deficit of greater than 12 definitely points out that there was an intrapartum hypoxia. Again, those numbers for you are your umbilical artery, and we're going to see a pH of less than 7 and a base deficit of greater than 12. Remember how base deficit works. That's how much base you have to add to that blood to bring it back to a normal pH level. So the more and more base deficit, no matter which way you go with it, that means that there's going to be a lot added back, which means there's a problem because it was very acidic. Number 11, a patient at 14 weeks gestation has an anti-RH big E titer completed. Paternal testing is completed for big E antigen. What is the best management based on the results? The results show anti-RH big E titer, maternal, at 1 in 32. Hopefully you recognize this as a critical level. RH big E antigen for the paternal testing that we completed shows negative. The answer to the question is C, observation. If you picked something related to the fact that you believe paternal testing isn't proven or it may not actually be the paternal of the pregnancy, you got to go ahead and let go of that. The exam is a perfect world. If they tell you it's the paternal person, then it's the paternal person. If they tell you the genetics are a certain way, the genetics are a certain way. If a test was done, it was done correctly, unless they lead you to believe otherwise. So things like teenagers telling the truth, they're telling the truth unless you're led to believe otherwise. So in the examination world, remember, everything is perfect unless you're told otherwise. Now, there is over 50 minor antigens that are available and known already. Only 3 are commonly associated with antibodies that cause severe fetal disease, and that would be your anti-cal, also known as K number 1, There is also anti-RH, lowercase or small c, and anti-RH, big E. Now, Duffy and Kidd antibodies are a less common cause of hemolytic disease of the fetus and newborn among atypical antigens that are present, but they also are known to cause severe disease. So that again is going to be Duffy. And Kidd. 12. Most states require that physicians who take a leave of absence greater than how many months need to participate in a physician reentry program? That's going to be answer B, 24 months. It's important for you to understand that if you take a leave more than 24 months in most states in the United States, you'll be required to do a physician reentry program. Physicians returning to practice most likely will not be paid during that time period, have to be watched and monitored by other physicians, regardless of being board certified or not, and may have to perform a certain amount of procedures before getting their privileges back at hospitals and with insurance companies. These programs often do cost for the physician that's taking them and can be considerably expensive. So again, if you're going to be taking leave from your job, make sure you're just back at 23 months to be safe, and then you don't have to worry about physician reentry programs. 13, while completing a hysteroscopic myomectomy, you are unable to see the anterior and posterior walls. There is difficulty filling the cavity. You deduce the uterine wall may be perforated. What is the next best step? The answer here is C, immediate laparotomy. Now you may be asking yourself, why can't I just do the laparoscopy? Well, because they're telling you you're going to complete the procedure first. You're doing a hysteroscopic myomectomy. You're either using some kind of electrosurgical or laser device or some kind of mechanical device that can cut or cause damage. Therefore, you may be causing damage to things outside of the uterus. So you are going to stop the major procedure that you're doing right now and convert to some form of seeing if there's damage or what the damage is. This could be done by laparoscopy, but again, you're not going to complete the procedure first. Standard for any kind of problem, concern, or emergency in obstetrics is to do obstetrics and gynecology is to do a laparotomy. So it is usually the better choice unless you can really make sense out of another choice that's present there. But be careful and make sure your answer makes sense, the entire thing, not just the part you want to be correct. 14. What type of ovarian tumor is likely to develop in a patient with androgen insensitivity after puberty? The answer here is going to be D, a gonadoblastoma. If you're thinking or looking for a seminoma, realize that gonadoblastoma is an overarching or umbrella category, and most of them are seminomas. Seminomas are what you're going to find as a germ cell tumor in these types of patients with androgen insensitivity syndrome. But again, they're in the larger category of gonadoblastoma. Be careful with what we call umbrella terms or more encompassing terms. They're often more likely the right answer because they encompass more answers that could be correct. So be careful with that and look for them. 15, the quantity of the fetal fraction is not affected by answer D, diabetes mellitus. Yes, unfortunately, there are what we call negative or reverse questions on examinations of a professional sense. Therefore, you do need to take your time, make sure you're reading the question correctly, and make sure you're looking for those excepts or nots or things such as that. Now, from our knowledge of writing examinations, we don't use except much at all anymore because it's been proven as a bad test taking strategy to use and a bad test writing strategy. Now, the quantity of the fetal fraction is affected by many factors, including to, but not limited to, gestational age, maternal body mass index or BMI, maternal medication exposure, race, aneuploidy status if present, fetal or maternal mosaicism, and single or multiple gestations. Now, depending on the laboratory or the cell-free DNA screening that you're done, it could be testing things differently. However, in the big picture, we know that it's not affected by diabetes mellitus, but the other things listed here are. One good thing about reverse or negative questions is these are all good answers or right answers. So it makes your studying a little bit easier by giving you some of those things to know on the opposite side of the question. Now, when it comes to cell-free DNA, make sure that you're aware that 4% is the bare minimum of the cell-free fraction that must be present by these tests to be considered sensitive and specific enough for result by ACOG. 16. The middle sacral artery is a branch of. The answer here is D, the aorta. Just like I tell medical students who are taking their gynecological rotation, I really need you to know about 13 inches of the human body really well for me right now, and that includes our pelvic vasculature. It's necessary and really important that we understand this area of the body and make sure that we can talk about it and figure out questions that go along with it. Now, if you notice, there's a small book in the right upper corner, which is the OB-GYN Illustrated. That's a book that you received with this course. If you want to make notes or just look at the picture on your own or the complete picture, we've put the page number there for you. So if you go to your OB-GYN Illustrated and open to page 44 in the 2024 edition, you'll find this picture. Now, also in this picture, an important crossing point is the ureter crossing over the bifurcation of the common iliac, turning into the external and the internal iliac. However, a lot of people don't know that's also the crossing point of the superior hypogastric plexus. I want you to just know that that's the superior hypogastric plexus. Number 17, which parenteral opioid analgesic used interpartum is associated with least risk of respiratory depression in the newborn? This is answer D, remifentanil. If remifentanil and fentanyl are put against each other, remifentanil is actually better. But we didn't put that in the question. But I want you to know that remifentanil is better overall for reducing the risk of respiratory depression in the newborn. 18. What is the origin of the DNA used to perform maternal cell-free DNA testing aneuploidy? This is going to be answer C, the placenta. Remember, these cells are coming off of the placenta and shedding into the maternal circulation, and that's where we're able to require them and use them for cell-free DNA testing. Now, that is why this remains a screening test. This is not a diagnostic test. Cell-free DNA testing is a screening test. It's coming from all of the same place that those cells originated from. However, the placenta grows faster than the rest of the pregnancy and therefore may have different genetics that show up or are altered throughout the pregnancy. Therefore, if there is a result that's concerning, it does need a follow-up with diagnostic testing, genetic counseling, and other things to be done for the patient. "19. Most common presenting symptom of vaginal carcinoma is going to be B, painless vaginal bleeding. Painless vaginal bleeding and discharge, if you were looking for it, are the most common symptoms of vaginal cancer. However, the only answer available here is painless vaginal bleeding. With more advanced tumors, you can see things like urinary retention, bladder spasm, hematuria, and even frequency of urination. So make sure you know some of these signs and symptoms of vaginal carcinoma. 20. You receive the results of hysterosalpingogram and you note bilateral dilated tubes consistent with hydrosalpinx. Which antibiotic is necessary after the procedure? This is A, doxycycline, 100 milligrams BID times 5 days. Now, if you're saying to yourself and you've read a practice bulletin regarding this examination, you say, wait a minute, dosages aren't really tested on this exam. True. However, I would always warn you that emergency dosages are fair game. Those are supposed to be memory items that you are supposed to know as a physician or provider in an emergency. However, knowing them for other drugs isn't really game. But I can also test you here on how often or frequently it needs to be taken and what the drug is itself. So you should be able to figure it out from those things as well too, because you have to know that this has to be given BID at least. It should be given for 5 days, not one dose. And it's 100 milligrams. If you got that part, you've got everything. Which is not an advantage of low molecular weight heparin? Number 21. The answer here is B, shorter half-life. However, it does lower the risk of heparin-induced thrombocytopenia, decreased bone density loss, and predictable therapeutic range. These are all true for low molecular weight heparin. However, it does not have a shorter half-life. 22. A 26-year-old presents with infertility. Which baseline study is least likely to assist in your management? This is answer D, an estradiol level. When looking at infertility, some of the best things that you need to know is 1, when talking about a couple being evaluated for infertility, male factor is present in up to 51.2% of those cases. So don't let that portion of the possibility escape your algorithm. After that, we see things like decreased ovarian reserve, which can be tested with things such as AMH or FSH levels at a basal amount, or things such as ovulatory factor could be another cause of primary infertility. Number 23. Which of these coagulation components are not affected by the estrogen in oral contraceptives? The answer here is A, antithrombin 3. It's important to understand oral contraceptives and pregnancy look alike as far as their effects on things. So antithrombin 3 is not affected by the estrogen in oral contraceptives. But let's take a look at our next slide and talk a little bit about pregnancy and coagulation. On this slide from OB-GYN Illustrated, page 15, we can see that coagulants are on the top and anticoagulants are on the bottom. I like to try to be simple and easy when I memorize things, especially lists like this that may have a lot of numbers and things in them. So what I would know is the things that go down are protein S, 13, and 11. I also would like to know that the things that stay the same are 2, 5, 9, and protein C. It's easy to remember that protein C and protein S are the only anticoagulants that I'm talking about here. The rest of them are numbers or have numbers in them, except for von Willebrand's and the increase in pregnancy. But really overall, I would just know the stay the same and what goes down, and the rest of them are going to be in that up arrow. So I know those increase in pregnancy. So again, the things that go down are 13, 11, and protein S. The things that stay the same are 2, 5, 9, and protein C. 24. A 72-year-old female presents to your office with dyspareunia and yellow vaginal discharge. Speculum exam reveals vaginal synechia and erosive friable patches. What is the best management here? The answer here is B, hydrocortisone acetate suppositories. I know you've been taught from day one of your residency, biopsy, biopsy, biopsy again, and then send a biopsy of the biopsy. However, if you read ACOG Practice Bulletin 224 and look at the literature, if you are very sure of the diagnosis, it states that you can treat and see if there is response before biopsy. If you're not sure of this diagnosis, let me help you out with it. This is a postmenopausal female where this is more likely to occur, and they're having dyspareunia, which is that painful sexual activity, which is due to the erosive friable patches and scar tissue that forms between them. And that yellow vaginal discharge, which usually has absolutely no order, is all very particular to erosive lichen planus. So again, we're talking about erosive lichen planus here, which has very particular signs and symptoms. And we've given you all of them in the stem above. So again, if you know what this is and you can treat it, you can go ahead and treat it and see if there is an effect in a reasonable amount of time, and you don't have to do that biopsy first. 25. A 29-year-old presents with a history of pelvic pain for several years. She reports a history of domestic violence. The most important additional screening for this visit would be answer D, depression. 26. Which of the following antimicrobials can decrease the serum concentration of estrogen and progesterone in a woman taking combined oral contraceptives? This is answer D, rifampin. Rifampin is well known to be something that causes a lot of problems for OCPs in our field. So let's take a look at some of the other metabolism of oral contraceptive issues that may be present there on our next slide. Things that may cause contraceptive failure are in the far left column. Those are things such as griseofulvin, primidone, rifampin, St. John's wort. And then in the second column, we see an increase in OCP activity. That's going to be things as simple as Tylenol, erythromycin, Prozac, fluoxetine, and grapefruit juice. Clearance decreased by OCPs is our third column from the left, and that's going to be amitriptyline, caffeine, diazepam, and phenytoin. Action may be decreased by the OCP is lamotrigine. That's in the last column or the follows this column to the right. 27. A 53-year-old with ovarian cancer is receiving paclitaxel or Taxol. Within seconds of starting, she experiences flushing, shortness of breath, and chest pain. The most likely cause of the symptoms is C, hypersensitivity. Common symptoms that go along with the drug Taxol or paclitaxel are things such as numbness and tingling, burning pain in a stocking glove distribution, peripheral neuropathy, which progresses with increased exposure and time, and it can even become debilitating, and alopecia, which is one of the most universal things that you see with paclitaxel, and it does result in total loss of body hair. Now, it is well known that paclitaxel also has a hypersensitivity reaction, especially when patients are taking it for the first time. Many infusion centers or hospitals that give this medication know to pre-dose the patient with hydrocortisone before ever even taking the actual drug. 28. A 22-year-old G1P0 presents at 8 weeks gestation by ultrasound. Her history includes seizure disorder and is treated with valproic acid. No seizures for 3 years. The most important next step is going to be D, perform quad screen and targeted ultrasound in second trimester. Out of the available options here, this is the best option to take. This patient's already at 8 weeks in gestation and therefore has been exposed to the drug through most of the beginning neurological and cardiac formation and other organogenesis in the pregnancy. Also, valproic acid has been controlling the seizures for over 3 years now. Taking this patient off this medication may put her at a large risk for having a seizure, which can be very dangerous during the pregnancy. Switching medications can also have the same outcome and therefore can be found as being dangerous. Let's go ahead and take a look at the next slide. This is a picture of Barbie and Vale. Barbie and Vale go toying around in their car. Barbie and Vale are parts of the Mattel family, so we'll give them recognition for that. However, we're just using this phrase to help us remember the bad ones and some of the good ones that go along with our anti-epileptic drugs. So in the bad ones category, Barbie is to remind you of phenobarbital. I always remember that Skipper was Barbie's true friend, so Vale must be a bad influence. And that's going to be valproic acid, which is by far the worst of the anti-epileptic medications. So she is a bad influence. Now they're going to go toying around in their car, and toying is going to remind us of phenytoin. And carbamazepine is for car. Now, carbamazepine is one of those ones that people get confused because technically oxycarbazepine is going to be one that is okay. So let's go ahead and do some okay ones over here. So I'll put a smiley face by our happy car drivers, and we'll put some of those drugs. I'm going to remind you to keep the Keppra and leave levetiracetam alone. And then because it's stubborn like an ox, oxycarbazepine can be left alone. So again, on this part over here by the car, we're looking at happy or good things that we would leave in place during a pregnancy. And then on the right side, we're looking at things that are bad for the pregnancy. Now, remember, this is preconception counseling. When you're going to talk to those patients about these medications, work with their neurologist or whoever is prescribing those medications to them to try to decrease and get onto another drug that's safer for pregnancy in a controlled fashion and over time. You're not going to do this really close to, and you're not going to do this when they are pregnant already. So make sure you understand that concept, and let's move on. 29. You are counseling a 22-year-old for starting oral contraceptive medication. Which of the following do you state they have an increased risk for? The answer is A, chlamydia infection. Chlamydia prefers to be in the area of the squamous-columnar junction, and it prefers that area overall. Therefore, when taking an oral contraceptive pill, you actually further expose the ectropion, and that is the area where chlamydia would like to be. Therefore, it's more highly exposed to it, and chlamydial infection will go up. It's also known that oftentimes when young people go onto contraceptive medications, they believe they're at less risk for getting sexually transmitted infections. And that's why we do heavy counseling reminding them that the birth control or contraceptive medication, for whatever reason they're using it, does not protect them against sexually transmitted infections. It can actually make it worse. 30. In the treatment of thyroid storm, which of the following is not effective management? The answer there is going to be D, potassium chloride every 6 hours until stabilized. Potassium iodide is part of the formulaic treatment of thyroid storm. However, it's not going to be potassium chloride. Now, I will talk about this in the OB-GYN Illustrated, which is included with your course, but we always remember PID. It's not just for pelvic inflammatory disease. It also helps us to remember the order of the medications that we're going to give for thyroid storm. Now you have to either give sodium iodide or potassium iodide up first. So that's the P, potassium iodide. You want to give that about every 8 hours. And the reason you're giving it first is because it has both a central and a peripheral blocking effect for thyroid storm. But it has to be completely separated from the iodide drug that you're going to give next. Now, the iodine can be given as such things as Lugol solution or heavy iodine, and that's going to be given to the patient about every 8 hours as well too, but it has to be about 4 to 6 hours after you give them the potassium. So therefore, remember those have to be separated. And the reason you're giving the potassium iodide up first is because it is going to be both blocking peripherally and centrally, where iodide's only blocking peripherally. Now, if a patient has an iodine allergy, what are you going to give them? If it's an anaphylactic history, you can actually give them lithium carbonate. So I would remember that as an allergy solution for iodine. Now, the last one there in the formula is going to be your dexamethasone. Dexamethasone is given about every 6 hours, and it's usually given as forms of hydrocortisone or dexamethasone. Either one will work. That also will have a blocking peripheral conversion effect on T4 to T3. Now, remember, there's also a beta blocking agent that's involved in the treatment of thyroid storm. This can be given anytime, and it's given whenever there is tachycardia. The second there's tachycardia, you want to be giving that beta blocking agent because that tachycardia can lead to both arrhythmias and pulmonary edema. So you want to make sure that you're giving that beta blocker agent as soon as there is a tachycardia present, and that can be given at any time during the algorithm, but it also has a peripheral blocking effect. "31. A 17-year-old G0 undergoes an exploratory laparotomy for a 9-centimeter pelvic mass. A frozen section of the right-sided mass shows Schiller-Duval bodies. The next best step here is going to be C, right adenexectomy and chemotherapy. Hopefully you recognize that Schiller-Duval bodies is a pathognomonic for endodermal sinus tumors or yolk sac tumors. This is a form of malignant germ cell tumors of the ovary, and its marker is usually AFP. So marker of AFP, and it's pathognomonic with Schiller-Duval bodies. And you want to remember again that this is an endodermal sinus tumor or a yolk sac tumor. 32. Prophylactic salpingo-oophorectomy reduces the risk of breast cancer in a woman with BRCA2 mutation by what percentage? This is D, greater than 40%. You have to be careful when you're reading ACOG Practice Bulletin 103 because it flips back and forth talking about protective and bad things related to BRCA1 or BRCA1 or BRCA2 or BRCA2 mutation carriers. Now, when it comes to the risk-reducing salpingo-oophorectomy, this reduces the risk of breast cancer by 40 to 70%. However, this protection likely occurs only if patients are premenopausal at the time of risk-reducing salpingo-oophorectomy. In addition, BRCA1 mutation carriers may have less of a protective effect from risk-reducing salpingo-oophorectomy on breast cancer risk than BRCA2 mutation carriers. So again, you have to be careful flipping back and forth between BRCA1 and BRCA2 in that discussion of risk-reducing things when it comes to breast cancer. So make sure you read it carefully, but hopefully we've broken it down for you here so you can remember it. 33. Which of the following is the most common breast cancer? This is answer C, infiltrating ductal carcinoma. This is the most common form of invasive breast cancer at 80%. It arises from the epithelial lining of the large or intermediate-sized ducts. I want to make sure that you understand it rises from the epithelial lining of the large or intermediate-sized ducts. That's important for you to know because it is the most common form of invasive breast cancer at 80%. 34. Which study type answers questions regarding risk factors for disease and prognosis? This is going to be answer D, prospective cohort studies. I just think of horses running forward because you don't ever really see them running backwards. So horses running forward, prospective cohort studies are looking for risk factors for disease and prognosis in the future or forward from where you're starting. 35. Functional residual capacity in pregnancy declines due to what physiological change? This is going to be answer B, elevation of the diaphragm. Pulmonary function and the physiological changes in lung function during pregnancy are really important. There's some stuff in the 5-star study guide to help you remember them if you have trouble with them, but I want to make sure that you understand they are important. Now, the reason this happens physiologically in pregnancy is due to the elevation of the diaphragm. And we mentioned that, but how much is actually impressive. It can raise approximately 4 centimeters. That's 1.57 inches during a pregnancy. No wonder these individuals have trouble taking a deep breath because that diaphragm really does raise high. 36. A woman is concerned that her 6-year-old daughter is developing breast. The least important step in your evaluation is C, karyotype. Karyotype is expensive, it takes time, and it unfortunately will not reveal much information here for you unless you have something else pointing to why you're doing a karyotype. So your initial workup, if you're going to do one, is serum estradiol level tests, bone age, or things like the gonadotropin releasing hormone challenge tests. This could be looking at precocious puberty, but oftentimes this is just a little one who's having some breast bud or something else that's just popping up spontaneously. However, you do want to look into these things. And when you do look into these things, if you're going to go into testing, these testings would prove more effective than doing a karyotype. 37. An 18-year-old G1P1 presents to your office with a known history of panhypopituitarism. Which of the following is the critical step in treatment? This is the answer C, cortisol. Cortisol, or hydrocortisone, is the most important human glucocorticoid. It's essential for life. It regulates and supports a variety of important things like cardiovascular, metabolic, immunologic, and homeostatic functions. Now, we usually give this as hydrocortisone in most of our patients, but again, in panhypopituitarism, you must have cortisol first before you take care of any of these other things. Cortisol is what responds to the stress response of the body and regulates its ability to deal with those stresses. And then you can think about things like the thyroid and the adrenal glands and so on and so forth. 38. The histologic feature of endometrial hyperplasia that is associated with the greatest risk of progression to invasive cancer is, this is C, nuclear atypia. If that nucleus is doing something abnormal, it's a very good sign that something is wrong with the cell, and it most likely is malignant or cancerous in process. Now remember, hyperplasias are further designated as usually atypical if they demonstrate nuclear atypia, and that was the old system between the EIN and the WHO. So the WHO is on its way out, and that's the penny, nickel, dime, quarter, or the complex, simple, with or without atypica. That's going to be our old system. We're now moving towards the new system, which is explained in your 5-star study guide. And we'll go through that when we review your 5-star study guide. But it's important to understand that EIN is what used to be complex atypical hyperplasia, and we want people to treat that. We want you to recognize that needs to be treated because there's actually a risk of up to 40 to 60% in some studies of it becoming cancer. So those are things like Megace, micronized progesterone, or other forms of progesterone for treatment. 39. Metastases to which organ system poses the least risk to a patient with gestational trophoblastic neoplasia? This is answer A, the lung. The lung does not increase the risk with a patient of gestational trophoblastic neoplasia. Now, you want to remember some important scores when it comes to things with the gestational trophoblastic disease FIGO scoring or WHO scoring, and that's things such as lung and vagina are FIGO 0. So again, lung and vagina are going to be 0. They're not going to contribute to your score at all. Now remember that a score less than 7 is going to equal single agent chemo, and then a score greater than 7 is going to equal multi-agent chemo. Let's take a look at that table and see if we can help ourselves with remembering it the best way possible. When I have tables like this or big complex things to study, again, I like to try to make it as simple as possible. I like to think like a test writer and think what things make the question extremely fair or very defined as an answer. Well, things that don't affect things at all, like the 0 column, or things that affect it contributively, which is going to be the 4 column. So I pay the most attention to the things in those columns to make sure I understand them and can recognize them. Things in the other columns definitely are fair game and can be there, but I know these things will affect the score in the biggest way possible, either driving it up closer to 7 or driving it down closer to 0 or less than 7. So therefore, if I'm looking for that treatment score, which is the point of this, I want to make sure that I know which things are going to drive it up the most and which things aren't going to affect it the most. But if you can learn the whole table, I encourage you to do so over time. However, this is an easier way to try to lock it in for answering questions on exams when you might be a little nervous and forget some information. 40. When compared with normal weight women, obese gravidas with a BMI less than 50 are least likely at risk for which of the following conditions? This is going to be answer A, fetal growth restriction. I want you to pay important attention to the BMI less than 50. We've actually found that BMIs greater than 50 put the pregnancy at risk for fetal growth restriction. This is much like the same of insulin-dependent diabetes mellitus going into a pregnancy, as we know that those patients also can result in fetal growth restriction in their pregnancies of their fetus. This is actually a metabolic demand equation is what we believe happens here. That BMI of greater than 50 or that insulin-dependent diabetes mellitus causes a greater amount of the energy to be transferred to the physiologic processes of the body by demand than by the pregnancy and the placenta's ability to try to call carbohydrates and sugar to itself. So just remember that BMI of 50 is important when it comes to fetal growth restriction or an infant being large. Forty-one. During a properly performed medial lateral episiotomy, the muscle that is transected is A, bulbocavernosus. Now we're going to fill in a picture next to make sure you understand the area of the perineum and that we understand the different things that are involved there. Let's take a look. On this picture, if you start with me from the top to the bottom, those pink lines are going to be that bulbocavernosus. Bulbocavernosus is often involved in perineal tears or perineal or oasis injuries, as it's the first exit point of the vagina and contributing to the anterior portion of the perineal body, which is a collection of many things that are shown here. Now, the next one down is going to be the superficial, the lighter green of the two. It's the superficial, transverse, perineal muscle. So again, the darker green down below here is just the transverse perineal muscle. Following that is the three orange colored lines, and the three orange colored lines are representing the muscles of levator ani. And then the blue circle around the letter R is going to be our external anal sphincter. Understanding this anatomy is really important, as repair of this area and the damage this area can cause for later pathology and issues for patients is very important. So make sure you understand the muscles of this area and what the repair of this area would look like. "42. A 29-year-old is admitted with bilateral tubal ovarian abscesses. Following a hysterectomy, there is gross contamination of the incision. You irrigate with saline. What is your next best step in management?" The answer here is leave open and pack with antibiotic gauze. The reason is you've contaminated the area that is underneath the skin, and if you close it, you're creating a lower oxygen environment where anaerobes and other bacteria that were exposed to it will grow and be very pleased to cause an infection in those areas. So again, if this area is exposed to those bacteria that is normally not coming from the abdominal area, it needs to be left open and packed with antibiotic gauze. 43. Which of the following is not an extraintestinal manifestation of Crohn's disease? This is answer A, glaucoma. If you were thinking something with the eye, there is one. It's a retinal problem that's going to go ahead and go with Crohn's disease. Knowing the difference between Crohn's disease and your irritable bowel disease forms are very important, including your colitis. So let's make sure we understand some of the extraintestinal manifestations that go along with Crohn's disease, because Crohn's can be anywhere. Now, some of those include things such as arthritis or arthropathies. The eye involvement, again, is going to be a retinal problem. There can be skin issues and disorders. Primary sclerosing cholangitis goes along with this, as well as secondary amyloidosis. Now, you can also see VTE and arterial thromboembolism, renal stones, bone loss, and osteoporosis. Vitamin B12 deficiency shows up with these patients, and there actually can be pulmonary involvement. So as you can see, it's a very long list of things that goes with Crohn's disease, but these are extraintestinal manifestations. I would recognize that they're extraintestinal, and that's going to be difference between the colitis, ulcerative colitis, and Crohn's disease. Ulcerative colitis is going to be all colon. 44. On average, epidural analgesia prolongs the second stage of labor by how many minutes? The answer here is A, 5 to 10 minutes. The answer from the actual study is 7.66 minutes. Just a strange number I happen to remember. But 5 to 10 minutes on average is going to be the prolongation of the second stage of labor. However, no other labor stages are affected by an epidural. 45. A 14-year-old presents with Swyer syndrome. Which of the following would not be a typical finding? This is going to be answer D, elevated testosterone levels. In Swyer syndrome, we like to also think of them as SR Wire syndrome. The reason for that is the genetic problem or issue is going to be the SRY region of the Y chromosome is not functioning. 46. Patient presents with family history of Down syndrome and is concerned regarding the risk for her pregnancy. The patient has a nuchal translucency completed. Which of the following results would be most predictive of risk? The answer here is going to be D. The timing is important, and also knowing the number, the measurement that is abnormal or a screen positive for a nuchal translucency. This should be completed between 10 and 14 weeks. And the measurement you need to know is 3.0 millimeters or greater. So again, answer D is the only one that satisfies both, with completed at 11 weeks between 10 and 14, and also 3 millimeters, which is an abnormal report. 47. The transformation of fallopian tube epithelium carcinoma begins with, this is answer C, development of stick lesion. Now, P53 may look familiar to you, but the P53 signature with strong immunopositivity is not actually a carcinoma at that point in time or a malignancy. It's the beginning stages of it leading to it, but when it actually becomes a carcinoma, it's characterized by development of the STIC or stick lesion. 48. Low malignant potential ovarian tumors are most characterized by which of the following? The answer here is actually D, no significant characteristics. Although 40 to 50% may show as a cystic mass within the ovary parenchyma, and they may have nodular vascularity involved, the majority still appear as if they're an endometrioma or other like pathologies. However, the biologic, behavioral, and pathologic features of the LMP or low malignant potential tumor of the ovary are distinct from their invasive counterpart. LMP tumors affect patients at a younger age, and they usually have a much better 5 to 20-year survival rate compared with invasive ovarian malignancies that could be other types of tumors. 49. A G1P0 at 32 weeks presents with differential cyanosis, dyspnea, fatigue, and dizziness. Exam reveals a loud P2 and a systolic murmur at the pulmonary area. ECG demonstrates right ventricular hypertrophy. What is the most likely diagnosis? This is C, Eisenmenger syndrome. If you don't remember Eisenmenger syndrome from medical school, not to bring back trauma for you, this refers to any untreated congenital cardiac defect with intracardiac communication that leads to pulmonary hypertension, reversal of flow, and cyanosis. That left to right shunt is converted into a right to left shunt secondary to that elevated pulmonary artery pressure and is associated with pulmonary vascular disease. So again, these individuals have a congenital cardiac defect that's left untreated and doesn't cure that intracardiac communication, which leads to pulmonary hypertension. So these are some things that I want you to recognize about these patients. And some of the signs and symptoms or complaints that you will see are swelling, volume retention, syncope, worsening cyanosis in the patient, palpitations, or hemoptysis. And those would go along with congenital heart disease presenting as Eisenmenger syndrome. 50. A monochorionic diamniotic pregnancy is diagnosed at 10 weeks by ultrasound. Which of these complications is the most common cause of morbidity and mortality? The answer here is D, preterm birth. Above all other things that possibly come pregnancy issues for multiple pregnancy, preterm birth will always be the largest cause of morbidity and mortality for these pregnancies and the outcomes of these pregnancies. Thank you for going through examination number 1 with me. I hope you enjoyed it. It's one of my favorite exams.